and was evaluated and found to have heart disease and was advised oral medications and counseled about surgical correction. The baby had bluish discoloration of skin and mucous membrane in lips, tongue, and nail beds when she started to walk, which was diagnosed at 1 year of age. She had history of easy fatigability, history of forehead swelling, sweating, history of cyanotic spell, diagnosed at 1 year.
No, right.
Is it visible now, sir?
No. Yeah.
History of forehead sweating present. History of cyanotic spell, which was diagnosed at 1 year of age, for which she went to hospital and which was settled with oral medications. History of recurrent respiratory tract infections once in every 2 months. No history of suck cycle. No history of weight loss. No history of chest pain, palpitation. No history of seizures, headache, fever, chills, and rigors.
Okay. Don't move this slide.
Yes, sir.
Is this a typical presentation of tetralogy of Fallot?
Bluish discoloration of skin and mucous membrane. And history of cyanotic spell.
But not forehead setting, not feeding difficulties, not palpitation. These
Yes,
are not these are signs of a left heart failure. So in a tetralogy,
yes, sir.
which conditions in tetralogy can have a left heart failure?
Sir, tetralogy with anemia. Tetralogy with pulmonary regurgitation, with pulmonary atresia.
Sorry, pulmonary regurgitation. That's a absent pulmonary valve syndrome produces right
Yes,
heart failure, not a left heart failure. The signs to describe here, and everybody says forehead sweating, I'm not very interested in that subject. The main thing is the feeding difficulties and recurrent respiratory tract infections, which does not occur in tetralogy fellow. These are two classical signs: feeding difficulties, failure to thrive.
Yes, sir.
And they are signs of a left heart failure. The left heart failure usually doesn't occur in tetralogy unless there are 2-3 conditions when it can occur. Can occur in a pulmonary atresia with large MAPCAs that can produce overcirculation and left heart failure. The other thing, after palliative surgery, when a shunt has been done, even if it's over shunting, then it can produce left heart. Or
Large PDA.
Large PDA can occur. Normally, the examiners ask you what are the causes of left heart failure in tetralogy of Fallot, or generally congestive failure. There are classical questions and there are classical answers for that.
Yes, sir.
In adults, in babies. In babies, I said, pulmonary atresia with large MAPCAs, okay, overdoing of the shunt. Which of the aortopulmonary shunt are usually overdone? Which
Large PDA, sir.
no. Surgically created aortopulmonary shunt. You mentioned all the shunts usually performed.
BT shunt, sir. Blalock tossing shunt. Watterson shunt. Pot shunt.
Right. It's the classic BT shunt and the modified BT shunt. Okay, yeah. Then water shunt, then water shunt Cooley shunt, pot shunt, the Gazzaniga shunt or the Chandler shunt, and the Me shunt or Roger Me shunt. These are the classically done shunts. Okay.
Yes, sir.
And when you say BT shunt, what is the approach for the BT shunt?
Sir, left subclavian artery attached with pulmonary artery.
I said, what is the approach? That means a surgical approach. Classically, it used to be done by a thoracotomy. Okay, usually left thoracotomy, okay, and from the left subclavian to the pulmonary arteries. What are the sizes of the shunt used in the modified BT shunt?
5 mm
No.
background.
5 mm if you put in a newborn, that's the most disastrous thing you can do. In the smallest baby, the shunt is 3.5 millimeter. That's because any shunt less than 3.5, usually they don't last because they get thrombosed. So classical, which is shunt in a newborn, is 3.5 millimeter or 5, can be 4 millimeter. Which is slightly bigger child, of course. You can put 5 millimeter. What's the difference between a classical BT shunt and a modified BT shunt?
Dacron graft is used in modified BT shunt.
Yeah. Dacron or Gore-Tex, whatever. Okay, yeah. And classical. Which side do you do the classical BT shunt? Right or the left?
Left side, sir.
I'm asking these things because the clinical part of pathology was discussed last time. I think we didn't have enough time, so we stopped at the stage of treatment. And that's why I'm asking you this classical questions. What is
Yes, sir.
whether the BT shunt should be done on the right side or the left side? Anybody can answer it. In other words, what's the incidence of right aortic arch in pathology of valve?
25%, sir.
45? No, that's a
25, 25.
25% is classically. And in that case, what is the branching pattern? What is the difference of the branching pattern? Because that's important from the point of view of approach for the classical BT shunt. The incidence of right aortic arch in pathology is 25%, and 90% of them is mirror image. What do you by mirror image? Normally, in a left-sided aortic arch, the first branch arising is the right innominate artery, which divides into the common carotid and the subclavian. In the right aortic arch, when you say 90% have got mirror image, the first branch arising is a left innominate, which divides into the left common carotid and left subclavian. Okay. That's the difference. So the mirror image of the normal branching pattern of the aortic. The other question asked Raju, which side you select to do a classical BT shunt? Because nobody does the classical BT shunt nowadays, but even that examiner might ask you.
Yes, sir.
Anybody can answer. I'm sure the seniors should know.
Side opposite to the
Good.
arch.
Good. Why is that? A very good answer. Okay.
It prevents the kinking of the anastomosis.
Not anastomosis.
In a classical, it is.
Because if it's a left aortic arch, the subclavian arises as a branch of the nominate. So if you take that, it forms a bigger curve. So it doesn't kink at that stage. You imagine in a left aortic arch, you try to do left subclavian artery, bring it down. It kinks on the aorta. No. You understand what I say? Because if I try to do a left BT shunt in the left aortic arch, you bring down the subclavian because subclavian arises at the top of the aortic arch. So if you try to bring it down, it produces a kink there. So that's why classical BT shunt is always done on the side opposite to the aortic arch or from the subclavian that arises from the innominate. Okay?
Yes, sir.
But I don't know whether you know there's a modification of classical BT shunt for a left aortic arch on the left side, which the Rax and Castaneda shunt. You know that. Or you refer that either. You refer what is Rax Castaneda shunt for doing left classical BT shunt in the left aortic arch. Yes, that's your homework. Yeah, proceed. And the other shunt. What's the difference between a Waterston shunt and a Waterston Cooley shunt? I'm sure some of the old examiners might ask you this.
Between thoracic aorta and pulmonary arteries, shunt between.
Don't say thoracic aorta. Thoracic aorta means nothing.
Ascending aorta, yes, sir.
Who can tell me the difference between the Waterston, the classical original Waterston shunt, and the Waterston Cooley shunt? Waterston Cooley shunt, then intrapericardial shunt. The original Waterston shunt was an extrapericardial shunt. Of course, the ascending aorta in that stage is intrapericardial, but in a Waterston classical shunt, you put the patient in a full lateral position and you do a full posterolateral thoracotomy. And then you dissect out the right pulmonary artery and at the ascending aorta, at that point, you enter the pericardium and then you put a side clamp on the ascending aorta and clamp the pulmonary arteries proximally and distally, or you snare it and make anastomosis the most posterior part of the ascending aorta. Otherwise, it will kink, You bring the right pulmonary artery, and then if it is not at the maximum posterior part of the ascending aorta, it kinks. So that's classical Waterston shunt done to a posterolateral thoracotomy. You don't open the pericardium first. Waterston Cooley shunt. Cooley modified it by doing anterolateral thoracotomy. Open the pericardium straight away. That's why Waterston Cooley shunt is called an intrapericardial shunt. At that stage, You see the ascending aorta, you see the superior vena cava, you retract the ascending aorta and the superior vena cava, and then dissect the right pulmonary artery, and then you make an anastomosis at the most posterior part. The problem with shunt, if it's not done at the most posterior part, to kink. So the flow may be more to one of the pulmonary arteries, or it may kink, stop flow from the other side. So that is the classical Waterston shunt and Waterston Cooley shunt. But is it done nowadays? What's the disadvantage of all those shunts? Actually, there is that's why Cooley introduced that Cooley clamp. If you look at the Cooley clamp, you can see markings, 0.5 centimeters, so that this the greatest disadvantage of pot shunt is the worst, then the water shunt is that can easily overdo it and flood the pulmonary arteries. Whereas BT shunt is partly limited by the size of the origin of the subclavian artery. So it cannot be overdone very much. Even then, if your large graft, interposition graft for modified BT shunt, it can overdo that. You have seen many cases, even in Narayana area, they try to clip, try to reduce the flow. So anyway, proceed. And the pot shunt is between what?
Pot shunt is between descending aorta and left pulmonary arteries.
Very good. That's the worst. Why I say it's worst? One, it can overflow too much shunt. And the worst thing is, it is one of the most difficult operations to undo at the time of open heart surgery, the second stage. Okay? But the shunt, whatever you do, it must be easy to take it down at the time of intracardiac repair. And pot shunt, probably one of the most difficult things in cardiac surgery to undo at the time of open heart surgery for total correction. You proceed now then. The slide is rotated up. The slide is rotated, upside down.
Sir, is
The
it okay,
slide
sir? No.
No, not that. Anyway, this slide you already put. Last time we described what
Yes, sir.
At what time do you see the maximum cyanotic spell? Enlarge it a little bit.
Sir, when the child becomes active, when it exerts, crying, and on feeding.
Yeah, you just understand the question. At what age of the baby?
Age, yes, sir. Around more than 6 months, sir, when the child starts to become active.
No, wrong answer. Last time I mentioned, 2 to 6 months is the maximum incidence of cyanotic spells occurs between 2 and 6 months. And gradually after 6 months, it becomes less and it's almost unknown after the age of 2. After the age of 2, when the child is walking and all, the cyanotic spells is replaced by a squatting. So that's a sequence all of you should understand, and the exam said that the maximum incidence of cyanotic spells is between 2 and 6 months. It becomes less and less after 6 months. Okay? And is cyanotic spell
Yes, sir.
more common in a very cyanotic child than a less cyanotic baby? I remember last time I said that it's often seen not in the most cyanotic babies. Those cyanotic babies are used to very low oxygen saturation for a long time. So it's not in the most cyanotic baby that the cyanotic spell occurs. It occurs in less desaturated kids, and also according to one of the theories, the Paul Wood's theory of cause of cyanotic spell, it's the infundibular spasm. So when that infundibulum is not in spasm, there's fairly a good pulmonary flow, and those kids are not very cyanotic at rest. Only when, as you were about to say, crying, feeding, difficulties, that time the infundibulum, because of the sympathetic overactivity, goes into spasm. They cannot cyanotic. And we describe the different physiological factors of cyanotic. So cyanotic spell occurs maximum between 2 and 6 months of the baby, and in the not in the most cyanotic, less cyanotic. Okay, then proceed. So these
Yes, sir.
symptoms you shown are not of tetralogy of Fallot. Okay, don't say
Yes, sir.
everybody says forehead, forehead. In a baby, there are 100 causes of forehead sweating. That's so. Don't say at the first stage. The classical signs of left heart failure is tachypnea, tachycardia, then failure, the difficulty in feeding. And difficulty in feeding is that the child, because it needs not a left heart failure. So that is what leads to the suck rest suck cycle. So when you suck a little bit time, the baby gets tired, even goes to sleep. So that is generally known as a feeding difficulty. It takes a long time to feed. Between the child after sucks, even goes to sleep, then again sucks. So the total time of feeding is very long. That is generally you say feeding difficulties. Then failure to thrive. That is more common, not in pathology, in VSD. The systemic output is less. ASD, all those considered heart conditions, they failure to thrive. And failure to thrive is usually the weight is affected more than height. The child, baby is 1 year old, we see the length because it's in a lying position. Otherwise, you say the height actually. Okay, proceed. Proceed with your presentation.
Yes, sir. Yes, sir.
Very small, and I can't read at this age.
Yes, sir.
Very small. Enlarge it a
Uh,
little bit.
Now, is it visible, sir?
Visible, it's all
Yes, sir.
anchored.
Birth history. She was born in via normal vaginal delivery with birth weight of 2.25 kg. At birth, no bluish discoloration, no PACO admission, exclusively breastfed till 6 months of age.
At what time after birth cyanosis appears in tetralogy of Fallot?
Uh, Mostly after the baby becomes active, sir. Uh, After 6 months.
That's not correct. Last time we discussed this. In tetralogy of Fallot, the cyanosis is usually delayed. Except delayed means it's not on from the day of birth. It usually starts after 2 weeks or 2-3 weeks. And actually, last time we described that also. You remember the reason for slightly delayed onset of cyanosis and tetralogy of Fallot?
Yes, sir. Uh,
What?
Sir, early PDA closure and child
Good.
becomes when
Yes.
child becomes more active and change of fetal hemoglobin to adult hemoglobin and uh, when dynamic component of pulmonary stenosis occurs.
Don't say pulmonary dynamic. It's a infundibular stenosis. The dynamic thing is part of the infundibular. Anyway, yeah. Fetal hemoglobin we described last time. Shift the oxyhemoglobin dissociation curve to the left. Because in intrauterine line, it's all fetal hemoglobin. So that whatever little oxygen it gets from the maternal circulation, it has to be used for the survival of the baby. At the time of birth, at 40 weeks usually, start converting from the fetal to the adult type of hemoglobin. And the presence of fetal hemoglobin may last even up to 6 months. So the presence of fetal hemoglobin is one reason because of the shift to the left of the oxyhemoglobin dissociation curve, cyanotic cyanotic. Whereas in pulmonary atresia with poor collateral, the cyanosis may appear from birth. So normally, cyanosis is slightly delayed in some. And 70%, some people say 66, two-thirds for the babies, the pathology are not cyanotic. And by about 6 months, 50% of all pathologies become okay. And what is the natural history of pathology of Fallot? It's been untreated. What happens in pathology?
Uh, Patient will develop cyanotic spell and
When you say natural history, that's not how you describe natural.
yes, sir.
Last time when you described ESD, we said 10% of all large VSDs die in the first year. Like that, in tetralogy of Fallot, untreated, what happens? The survival at the end of 1 year is about 66%. The survival at the end of 3 years is about 50%. And the survival at the end of 10 years is only about 25%. After that, there's only gradual loss of life in tetralogy. Okay, so these are the figures you should understand. At birth, 70% of the tetralogies are acyanotic, but by about 6 months, 50% of the tetralogies become cyanotic. And the life expectancy of tetralogy. Okay, all right. Go to the next slide. I'm saying this because these are some of the questions usually examiners ask during an examination. Okay.
Family history.
Yeah.
Family history.
Yeah.
Non-consanguineous marriage. No history of congenital heart disease in the family. Mother had
What
no
is
issues
important?
during antenatal period.
What is the importance of the tetralogy of Fallot in the family? Suppose one child has got tetralogy of Fallot, what are the chances of the second child getting TOF? These are all given in all textbooks. Normally we say if an elder sibling has got TOF, 2.5% chance that the second child may get TOF. And if two siblings have got TOF, the chance of the third one getting is between 8 and 10%. And what about suppose the mother has tetralogy corrected and has baby? What the chance of the baby getting tetralogy of Fallot?
30%.
No, that's also 2.5%. Just like the sibling. Mother's 2.5, father is 1%. The presence of tetralogy treated in a mother, the chance of the baby getting tetralogy is 2.5%. Suppose the father has tetralogy, then it's only 1%. Okay. So that's the importance of history, family history of tetralogy of Fallot. Okay, right. Good. Next.
Immunization history, fully immunized till age.
Okay. All right.
Developmental history, the
Yeah.
baby can walk and run, no developmental delay, normal IQ, language, can speak words fluently, all developmental milestones achieved for age.
Okay.
Personal history, mixed diet, good appetite, normal bowel bladder habits, adequate sleep. Surgical history, no history of previous surgeries. Family history, not significant. Treatment history, tablet Indrall, 10 milligram, half tablet TAD.
Okay. So you mean to say the child can run? You said the child used to get cyanotic spells, is it? I thought you
Yes,
said
sir, that is well controlled with medications. Sir. With propranolol, it is
up to
coming
what
down.
age
Sir.
you got?
Uh, patient was diagnosed with TOF at 1 year of age, sir. Now currently 1 year, 10 months. Sir.
So the child can run now, is it?
But cynosed only, sir.
Yeah. Does he get squatting spells? Squatting?
No, sir. No, sir.
Not squat. Okay. Okay, proceed.
Summary. A 1 year, 10 months old girl child born out of non-consanguineous marriage, diagnosed with heart disease at 2 days of birth, now presented with complaints of recurrent respiratory tract infections, bluish discoloration of skin and mucous membrane on exertion, had a cyanotic spell diagnosed at 1 year of age with EC fatigability and excessive forehead sweating, no successive cycle, probably cyanotic congenital heart disease of Fallott's physiology.
Recurrent respiratory tract infection is a symptom of tetralogy of Fallot, is it?
No, sir.
What's the
Might
cause?
be some additional shunts.
What's the cause of recurrent respiratory tract infections and which condition is present?
Sir, increased blood flow because of left to right shunts can cause recurrent respiratory tract infections.
Very large left to right shunts, where it's atrial level or ventricular level or the arterial level produces recurrent respiratory tract infections. We have discussed this many times. What is the cause, how it produces recurrent respiratory tract infections, and what exactly is the definition. So I'm not going into that now. Okay. So it's tetralogy physiology.
Yes, sir.
What do you mean by tetralogy physiology?
Sir, it is a cyanotic heart disease which can be uh, tricuspid, tricuspid atresia, transposition of great arteries, truncus arteriosus, tetralogy of Fallot.
Don't say that transposition of the great arteries. That's not tetralogy physiology. In tetralogy of physiology, there should be a hole in the heart and there should be reduced flow into the pulmonary arteries. So, in a transposition of the great arteries, actually the systemic arteries connected to the pulmonary circulation. So you must say the most common things are pathology of fellow, DORV with pulmonary stenosis, the tricuspid atresia with VSD with pulmonary stenosis. And if you say transposition of the great arteries with VSD with pulmonary stenosis. Pulmonary stenosis should be present in all cases. Tricuspid atresia with a VSD with pulmonary stenosis. Transposition of the great arteries with a VSD with pulmonary stenosis or DOVPS, single ventricle with pulmonary. All these things come into the category of tetralogy physiology because there is a reduced pulmonary circulation. So that all this comes in the classification of Fallot's physiology. Now proceed, you can.
Yes, sir. General physical examination. The child is conscious, alert, playful, cooperative, and was lying comfortably on the bed.
Slide is gone. I don't know what happens.
Is it visible now, sir?
Yeah.
The child is conscious, alert, playful, cooperative, and was lying comfortably down on the bed. She was examined after taking consent and in presence of her mother. Weight was 9.9 kg and height of 80 centimeter. Cyanosis present. No pallor. It was.
That's normal for this age, or is that the height and the weight?
Yes, sir.
Okay.
No pallor, icterus, clubbing, generalized lymphadenopathy, pedal edema. Head to toe examination is normal.
Okay.
Vitals, pulse rate of 126 beats per minute, sinus rhythm, normal in volume, character, no radio-radial delay, respiratory rate of 28 per minute, saturation of 70% in room air, BP 90.
Why do you say radio delay? People always start by saying no radio femoral delay and no radio radial delay. Why you didn't mention radio femoral delay in this case at all?
Sorry, sir, I missed it.
Yeah? There's an explanation for that actually.
So right side obstruction with left side obstruction is not sustainable for life. If it is, she is expecting coarctation.
The incidence of coarctation in tetralogy is almost nil, extremely low. Why is that extremely low? What are theories of coarctation? There are two theories. One is a ductal
Flow therapy and
huh?
flow Flow theory
Flow
and
Flow theory, yeah. Flow theory, because when there is infundibular and pulmonary valve stenosis, the flow, because there's a large VSD and it's almost like a common ventricle with equalization of pressures between the right and the left ventricle. When there's less flow to the pulmonary arteries, most of the blood goes into the aorta. And according to the flow theory, when the aortic flow is less only, that may lead to coarctation. So much so, coarctation and pathology usually don't coexist. All right. You can proceed. SPO to
Yes, sir.
70%. At what percent usually the cyanosis appears?
Sir, in central cyanosis, if saturation is less than 85%, cyanosis occurs, sir.
What's the cause of cyanosis in central cyanosis?
Right to left chance.
No. What about the reduced hemoglobin? What is the amount of reduced hemoglobin in the peripheral circulation in the capillaries? You want to say that cyanosis appears. Who answered that? The cause of cyanosis is the amount of reduced hemoglobin in the periphery, in the capillaries. What's the percentage actually of reduced hemoglobin?
30% or more than 5 grams of reduced hemoglobin.
5 gram percent. It's roughly 5 gram percent. That's why very often you say that a very anemic patient doesn't become cyanotic.
Cyanotic.
If the patient's hemoglobin is 5, it has to be 100% desaturated before it becomes cyanotic. So what a normal hemoglobin you expect in a tetralogy of valve?
Polycythemia will be there, sir. More than normal range, like more than 16.
14 is usually you expect hemoglobin of 14% gram percent. If it is less than, usually it's an anemia. It's defined as anemia and tetralogy of valve. Okay. All right. Good. Proceed.
Yes, sir.
That's why
Febrile at the
many of
time
the,
of examination.
that's why many of the patients with tetralogy, the hemoglobin is less than that. You treat them with packed cells, Okay. Otherwise, I think you mentioned earlier, anemia can lead to cyanotic spells also. Fever can lead to cyanotic spells, and if accidentally anybody gives ACE inhibitor, all these things can lead to cyanotic spells. All right, okay.
Yes, sir. Febrile at the time of examination, weight 9.9 kg, height 80 centimeter, BMI of 15.5 kg per meter square, which is appropriate for age.
All right.
Serious examination, inspection, chest is bilaterally symmetrical,
No
trachea
slides.
appears to be in midline.
No slides. Okay.
Yes, sir. Serious examination, inspection, chest is bilaterally symmetrical, trachea appears to be in midline, apical impulse seen lateral to mid-clavicular line, no visible pulsations, no chest deformities, no visible scars.
What visible scars are you looking for?
Any previous surgical scars.
Where do you expect the
Palpation.
scars? Classically, they used to do a left thoracotomy and do BT shunt, which is changed now. In Narayana area, what is the usual approach for a modified BT shunt? Usually done through midline nowadays. Okay? All right. Okay.
Okay.
Of course, your second year, you've not seen that. But most of the pediatric cardiac surgeons now prefer to do BT shunt if required. Of course, they don't do much of BT shunt. Change to a midline approach. Next one. And the central shunt is always done through a midline sternotomy. Okay. Next one.
Palpation.
Yeah.
Palpation. Trachea and midline. Apex beat felt at left fifth intercostal space, 1 centimeter lateral to mid-clavicular line. Palpable P2 present. Parasternal pulsations present. No thrill.
It's very strange. Just put that on. Don't change that.
Yes, sir.
What happened to the pulmonary second sound in tautology? What is the character of the second heart sound in tautology?
Usually, second heart sound will be single, sir. Overriding, because of overriding of aorta, it will be single S2. P2 will be silent, but in this patient, it was palpable P2 was present. Sir.
It's very rare, Tautology, the P2 is either absent or even very mildly heard, so much so what you hear is aortic second sound most prominently. Here exactly opposite. P2 is a sign of what? And accentuated P2 is sign of what?
Pulmonary hypertension.
Pulmonary hypertension, which never occurs in tautology of valve. So there must be something wrong. You missed some finding. You may be hearing the A2. Okay.
Yes, sir.
The classical finding is A2 is prominent and P2 is not heard or very soft. That's the usual description. Go on, next one. Parasternal pulse. Any thrill?
No thrill, sir.
Parasternal pulsations, I don't know what it is. By palpation. You say parasternal heave. That's what the definition is that when you palpate the parasternal heave, 1 or 2 or 3 grade, That's also usually.
It can be grade 2 parasternal heave, sir. Pulsations felt, but after giving pressure, it was not there. Parasternal pulsations only.
Usually in tautology of paro, you don't get parasternal heave of grade 2. There's equalization of the pressures in right and the left ventricle. So the pressure can never go above the left ventricular pressure. The very high grade 3 type of parasternal heave is not heard actually. Every day Krishna goes on, quiet precordium. Usually it's the parasternal heave is absent in tautology of Palo, unless it has got some complicated type of tautology of Palo. It can occur in some cases of where the tricuspid valve has become attached to the ventricular septal defect. Like we said earlier, one of the mechanisms of closure of a ventricular septal defect is the fusing of the chordate of the septal leaflet of the tricuspid valve and getting attached to the ventricular septal defect and making the ventricular septal defect fall. And in such cases with pulmonary stenosis, right ventricular pressure can be even suprasystemic. That's why when I enumerated the cause of heart failure or right heart failure, in pathology follow, one condition is that the septal leaflet of the tricuspid valve is attached to the VSD. VSD becomes small, and because it's pulmonary stenosis, the right ventricle cannot empty into the aorta very much. It cannot empty into the pulmonary artery because of pulmonary. Some of them can go into right heart failure, similar to absent pulmonary valve syndrome. These are the two conditions where the right heart failure can occur in tetralogy. Okay? All right, this was your general information I'm saying. Usually it's a quiet recording. Sometimes children may be stressed because grade of mama, injection systolic mama, maybe 3 to 5 out of 6. Anything more than 4 may give a 3. Okay, next. So the palpable P2 I'm very doubtful. Okay, next one, auscultation.
Auscultation. S1 normal, loud P2. Ejection systolic murmur of. Yes, sir. Ejection systolic murmur of grade 3/6 heard over the left second and third intercostal space along left sternal border. No additional murmurs heard.
Okay. What's the cause of that ejection systolic murmur?
Infundibular stenosis.
What's the percentage of infundibular? What is the percentage of stenosis of the right ventricle outflow tract in tetralogy of Adam? Or what are the different types of RV outflow tract stenosis in tetralogy? Because the most important criteria, either for surgical correction or is the infundibular stenosis. So what percentage of infundibular stenosis you expect in tetralogy in classical tetralogy? I think I mentioned it last time. Textbooks say 45% of the tetralogies will have infundibular and infundibular plus valvular stenosis is another 30%, so 75% will be there. But isolated pulmonary valve stenosis alone without infundibular stenosis is present only 10% of tetralogy of valve. And then there may be pulmonary annular stenosis and hyperplasia of the main pulmonary artery, hyperplasia of the right or the left pulmonary artery, and there may be origin of the one of the pulmonary artery origin stenosis, and that most common is the left pulmonary artery origin stenosis. So you should know what is the anatomy of the artery of tract in tetralogy. This is the anatomy. All right. No additional murmur. All right. So sometimes you can hear a PDA murmur. All right. Next one.
Other system examination. Respiratory system, normal vesicular breath sounds heard, no added sounds. Central nervous system, no focal neurological deficit. For abdomen, soft, non-tender, and no organomegaly.
Okay.
Probable diagnosis, 1 year, 10 months.
Go on again. No slide.
Sir?
No slide.
Yes. Probable diagnosis, a 1 year, 10-month girl child with congenital cyanotic heart disease with features of pulmonary arterial hypertension, with no features of congestive cardiac failure, infective endocarditis, thromboembolic events, likely tetralogy of Fallot.
You have made one of the most disastrous diagnosis with features of pulmonary arterial hypertension.
Sir, palpable P2 and loud P2 was there, so I have mentioned that, sir.
That's pulmonary arterial hypertension occur in tetralogy of Fallot. A low pulmonary flow situation. I said the only exception is a MAPCAS or a surgically created shunt, high flow shunt. Otherwise, pulmonary arterial hypertension never occurs in tetralogy of Fallot. And the diagnosis is wrong. Okay, proceed. Even if they don't mention that in an exam, if you get a diagnosis of tetralogy, don't mention pulmonary arterial hypertension. Okay, all right.
Okay, sir. Investigation, chest X-ray.
Yeah,
Trachea is deviated to the right.
I think it's rotated also. Yeah.
Yes, sir. Rotated X-ray. And trachea deviated to the right. CT ratio of 0.7. Equivocal apex. Pulmonary base full.
So this is not a classical picture, not a classical picture of a X-ray of
TOF.
tetralogy. What a classical appearance of tetralogy of Fallot.
Boot-shaped heart. Coherence about.
What boot is it?
Boot-shaped heart.
Dutch boot, the Dutch farmers used to wear. So the classical appearance, why does this boot-shaped heart occur?
Sir, because of RV apex will be upturned and pulmonary bay will be empty.
Yeah, that's important thing. The upturned part because of right ventricle hypertrophy, and it's not a left heart type of apex. And most important thing, the part of the boot, because of the pulmonary bay, is prominent. Or the pulmonary corners is not prominent at all. It gives the appearance of a bay, and both together upturned apex and the bay gives the appearance of a Dutch boot, the Coron Sabo. It is. Okay. And polygamic lung fields, but that's not in this. It's not very polygamic. Okay, all right.
ECG, sir. In this ECG, chest leads are not there, sir. Only limb leads are there.
Not seen. No slide.
Network issues, sir.
Yeah, now I can see. Yeah.
Yes, sir.
Come on.
Sir, in this ECG, chest leads are not there. Only limb leads are there, sir.
Okay. Why is that? Yeah, you describe the ECG.
Sir, right axis deviation is present, sir. In lead 1 and lead AVF, positive deflection of QRS complex. So it is normal to right axis deviation.
You cannot diagnose a tetralogy of Fallot without the chest leads.
Chest leads, yes, yes.
So, what are the other features of a tetralogy of Fallot?
Right bundle branch block, like peaked QRS complex and deepened S waves.
The axis
In tetralogy of Fallot, it will be right axis deviation.
you say a severely cyanotic tetralogy of axis usually very much to the right, that means about 120 to 150. In acyanotic tetralogy of Fallot, the axis may be slightly, maybe normal, or even slightly between 90 and 120. Normally you expect, you call minus 30 to 90 is normal. So in a acyanotic tetralogy of Fallot, the right axis deviation may be about 90 to 120. Whereas in a severely cyanotic tetralogy of Fallot, the axis is more than 120 up to 150. Then what happens in a different type of tetralogy of Fallot? Is there any other type of axis in any other type of tetralogy of Fallot? What are the variations of all the ventricular septal defects in tetralogy of Fallot? Classically, what is the VSD in tetralogy of Fallot?
So large anterior subaortic perimembranous VSD.
What is the anterior VSD?
Anterior malaligned.
Large subaortic, non-restrictive, malaligned VSD.
Very good. So usually it's a perimembranous VSD, usually with extension. Perimembranous VSD alone will not give a large VSD, which is actually defined as almost 75% or to 100% to the size of the aortic annulus. So normally the perimembranous VSD usually extends into the muscular part of the VSD in one type, into paratricuspid inlet defect, which is canal type of VSD. That's where there's a left axis deviation. So that's the only condition. Of a canal type of VSD in tetralogy of Fallot, where the VSD from the perimembranous area extends inferiorly paratricuspid. And the other type is extension of the perimembranous VSD subpulmonically. It's a doubly committed. That means from the subaortic area, it extends to the subpulmonic area, which, what do they call? Call it the Asian type of pathology. Normally, that type of VSD is in Western literature seen in 5%, whereas in Asian countries like Japan, China, probably a part of India, it's about 30%. Extends from the subaortic area to the subpulmonic area, or into the infundibular septum, its extension. So what do you mean by malaligned? I'm asking you the third time actually this week. What do you mean by malaligned?
Because of antrocephalad conoseptum development, sir. Your aorta will be overriding and pulmonary artery will be stenosed. That is causing malalignment of septal development.
Malalignment of what?
Conoseptum.
Yeah, good. It's a infundibular corner septum. In normal development of the heart, the infundibular septum comes down and gets attached to trabecular septum marginalis. Trabecular septum marginalis, they've got a body and two. One is the paratricuspid rightward inferior extension of the limb, which is known as the septal limb. One is on to the left side and the anteriorly is the parietal band and the septal band. And the body of the trabecular septum marginalis. Normally, the infundibular septum comes and gets attached to the body of the trabecular septum marginalis and its two limbs. In a malaligned VSD, it is rotated anteriorly and leftwards. So much so that anterior and leftward movement of the infundibular septum causes two things. One, a large malaligned VSD. Two, it produces infundibular obstruction because it's under the under the pulmonary valve. It produces the infundibular obstruction as well as a large malaligned VSD. And that's the same reason why malaligned VSD can never close, So the child grows the two infundibular septum and the trabecular, they move apart and becomes larger actually. So it doesn't close. So what's the classical ECG tautology? One, we said axis, right axis deviation, extreme right axis deviation in case of severe tautology of Fallot, left axis deviation in a AV canal type of ESD. Then, without a chest lead, tautology cannot be done. What's the most important feature? ECG in tautology.
Right ventricular hypertrophy.
That
Teacher.
we said, right ventricular, already said.
Early transition.
Most important.
Early transition, sir.
Yeah, early and sudden transition. That's what you should say. Early and sudden transition between V1 and V2. That means in V1 you see monophasic high RV, and in V2 you see RS pattern. The sudden transition occurs early between V1 and V2. That's it. And normally the left ventricular forces are less, so you don't see the left ventricular hypertrophy in tautology of Fallot. And the volume overload usually never occurs unless there's a MACA or overdone shunt. Then Q waves may appear, but the very tall R waves and left ventricular hypertrophy doesn't occur in tautology of Fallot. So classically you have to answer the early sudden transition between V1 and V2 in the chest phase. Okay, all right, next one. These are simple questions, but should answer them.
Sir, one more doubt, sir.
Yeah.
Sir, regarding clockwise and anti-clockwise grouping, sir.
Yeah.
Can you give us some idea, sir?
Normally in tautology, there's an anti-clockwise rotation of because the right ventricle more comes to the right side, and the aorta becomes very prominent. That's the cause of a very loud A2 in that case of tautology. Is an anti-clockwise rotation. Okay, next one.
Echoes.
Yeah.
Impression. SDS, levocardia, tetralogy of Fallot, large conoventricular anterior malaligned VSD, BD shunt, severe subvalvular and valvular PS, patent foramen ovale, left to right shunt, left aortic arch, coronaries unclear, confluent branch PS, bilateral SVCs, small PDA or collaterals, good biventricular function.
Okay. So this gives you all the information you want or not?
Yes, sir.
It doesn't. It doesn't.
Patient has bidirectional shunt, has patent foramen ovale and small PDA. That's why cardiomegaly was there in X-ray.
No, what I meant is the coronaries are unclear. So you're not going to do a total
Cath,
correction with coronaries because in a good echocardiography, what you are expected to see the proximal parts of the coronary artery, especially the right coronary artery and its branches, and where there is a abnormal branch forming the LAD. That's a common anomaly of the tetralogy. How many percentage of tetralogy will have abnormality of the coronary artery?
5%, sir.
5%, correct. And that's classically taught 5%. And the most common,
Conal branch, sir.
yeah, a coronary
Crossing
branch
RVD.
crossing the RV outflow and then becoming the whole LAD or part of the LAD. Sometimes there may be a small LAD from the left coronary also, but in many cases, the large corner branches, the branch from the whole LAD. That's a dangerous type because that patient, if there's annulus narrowing or needs a transanular patch, your coronary comes in the way and you have to do something else. And the most dangerous thing is a single coronary artery crossing the artery outflow. That means the right coronary artery right in the right coronary may cross. They may give the right coronary artery as well as the LAD as a circumference. Single coronary artery. Those are most dangerous things if you need a transanular. So 5% is it. Okay. And the other thing is, you have to have a Magon ratio and the Nakata index mentioned in the echocardiography to decide on whether you can do a total correction or whether you have to do something else. So that's also not mentioned. No?
Not mentioned, sir.
So they've said something about the PA size, 7 millimeters. Last time we described, no? What the normal Magon ratio, what is the ratio where you can do a total correction, what the Nakata index normal, and where you can cannot do a intracardiac repair. Ejection fraction is okay. That's not a authorization in case of tetralogy, unless it's a very old tetralogy. Elderly patient with tetralogy, because of the cyanosis, there may be a ischemic cardiomyopathy thing like that. The myocardium function becomes less lethal, but that's a rare thing because long-term cyanosis may produce that, but that's not relevant in small babies and children. But what Magoon ratio, you said, what is Magoon ratio? You can appear for an exam without knowing what's Magoon ratio. Who will answer among the seniors? What is Magoon ratio? I'm very surprised at
The ratio of diameter of pre-branching of RPA with LPA to that of thoracic aorta at the diaphragm level.
very good. Descending thoracic aorta at the diaphragm. Why the pre-branching thing important? The correct definition. And normally what is it? Magoon ratio.
Normally 2 to 2.5.
Very good. 2 to 2.5 accepted. Is a pre-branching diameter of the right plus left pulmonary artery to ratio to the diameter of the descending thoracic aorta at the diaphragm level. Why is the pre-branching? Because if you put a patch and enlarge in case of hypoplasia of the pulmonary arteries, you can go only up to the pre-branching. Beyond that, when the pulmonary artery is already branching, you cannot put a transannular patch and enlarge it. So much of that's why I said if the pre-branching, that's why you take consideration of the pre-branching. Because if pre-branching ratio is less, you can put the main pulmonary artery or the right pulmonary artery or the left pulmonary artery are narrow, you can enlarge it with a pericardial patch. But if it goes to the branching level, you cannot enlarge the size. So if you do total correction, what happens if you do total correction in a case which is not suitable? What happens? You close the VSD and you put a patch. The most important thing at the end of cardiac surgery is the RV-LV pressure ratio. What is the ideal RV-LV pressure ratio we expect at the end of a total correction?
More than 0.7 and more.
0.7 is accepted. So if you don't put a patch for long enough, you may have either above 0.7 or even systemic. So that is a very bad condition usually. They may not even survive. So your idea is to get a RVLV pressure ratio of less than 0.7 after correction. That's the importance of Magoon ratio. What is Nakata index? Magoon is a ratio, Nakata is an index.
Cross-sectional area of LPA and RPA to that of the body surface area.
Yeah, it's an index. That means the body surface area. Not the normal Nakata index.
250 to 300.
Huh?
250 to 300 is normal.
No.
300 to 3.
Very low. These are 300 plus or minus 30. I mean, up to 330 plus or minus. 250 is the low, is below the normal. So previously we used to think 330 plus or minus 30, but nowadays people say 300. At least 300 should be the Nakata index. At the lowest, what Nakata index will you do a total correction?
More than 100 is recommended.
Yeah, I think more than 100 is okay. And more than 150 or 180 for a Rastelli and a 240 for a Fontaine type of opera. So what are you going to do? Here, the proximal coronaries are not visualized. So what do you do?
Cardiac catheterization.
No, that's not what done in this hospital. A CT angio, because a CT angio will give you exactly the information, and cardiac catheterization has been given up after the, now you've got 256 CT angio, and it gives absolute information. And no need for cardiac catheterization, because in a baby to do cardiac catheterization and to you can't have a selective coronary artery injections in them. So cardiac catheterization is out nowadays. You do CT angio. What are the conditions where you will do a shunt rather than a total correction?
Sir, when baby has frequent cyanotic spell,
That's not an
and
indication.
when it is less than 1 year of age,
That's why he can't operate before. You can't do a total correction before 1 year of age. Wrong.
During cyanotic spells, sir.
That's not an indication of a shunt.
PA is not adequate size.
Yeah. There's general hypoplasia of the whole pulmonary artery, both right and left up to the hilum, and the Magoon ratio is less than one. In that case, total correction may end in disaster because the RV pressure ratio may even suprasystemic. So in such cases, the generalized hypoplasia in a baby, it's an indication not to do that total correction. Then
The peripheral pulmonary artery stenosis.
that's not a nowadays cardiac they coronaries will dilate the peripheral pulmonary artery or even put a stent. The classically it's a few things. One, patient with a Swiss cheese type of defect, multiple VSDs, Swiss etiology, which is of course less than 2%, is a contraindication to do total correction. That's so it is one of the indications to do aortopulmonary shunt. One, multiple VSD. Then large coronary artery crossing the infundibulum at the area, and if the patient needs a transfemoral path, that's a contraindication to etiology, total correction. Then you do shunt. In the recommendations of the Indian cardiac is that weight below 2.5 kilo. So that most people don't agree. It all depends on how good the cardiac surgery center is. So the weight of less than 2.5 is not now taken as a contraindication for tetralogy. Can be corrected at any age. Classically, in this hospital, patient with mild stenosis, the tetralogy is corrected between 6 and 12 months, 1 year. Previously, we used to teach that it should be corrected tetralogy, not having cyanotic spells or anything, well controlled with beta blockers, 1 to 2 years. But in this hospital, in advanced hospital, the tetralogy is corrected between 6 and 12 months. But you can do tetralogy correction even in the baby of 3 months, provided all the criteria is satisfied and provided the annulus is not narrow. Why is that? By calculating the Z value of the pulmonary annulus. Because in a baby, babies less than 3 months do not tolerate a transannular patch very much. So the Kirkland said, even a baby less than 3 months, a transannular patch is required. It's better to do a shunt rather than correction. And how do you decide that preoperatively? That's decided by the Z value of the pulmonary annulus compared to the body surface area. There's a Z value given. If it is -3 or more, that -2 or 1 or something, that patient may not require a transannular patch, or tetralogy can be corrected at any age. But in this hospital, if it is transannular patch is required less than 3 months, they don't do total correction. But above that, even 3 months, if the anatomy is adequate, it can be corrected provided the transannular patch is required. And classically in this hospital, the ideal age is 6 months, 12 months tetralogy correction is done.
Even the coronary artery crossing is a contraindication, sir.
Yes, coronary artery crossing is a contraindication because you don't want to do a rastally a conduit from the right ventricle to the pulmonary artery in a child less than 10 kilogram or 1 year old, you know. So that's a classical teaching. But some people say if you can do a trans-atrial correction of tetralogy, pulmonary arteriotomy and resect the infundibulum as much as possible, both from the atrium and the pulmonary artery, and that puts a small patch above the coronary artery, and then put a double barrel type. What means double barrel means put a graft of 8 millimeter from the right ventricle to the pulmonary artery. So much so there are 2 openings from the right ventricle, one through the natural route and one that's known as the double barrel. That also people don't do very much. It's a very complicated thing to correct. So in this hospital, I think the policy is to do a rastally. If the child is 10 kilograms, the coronary artery is crossed. The other thing described by Bonchek was actually lift the coronary artery from the RV outflow and put a patch below that. That's condemned and not many people even recommend that operation. What conduit is used in this hospital for a rastally procedure? Finally, I'm sure you must have seen. So there's that actually. You should put a Gore-Tex.
Vortex valve conduit, yes.
Conduit with a Gore-Tex thin membrane, they make something like a valve, because otherwise it produces a massive pulmonary regurgitation. So what they do is to put a graft of cortex with a cortex membrane made like a valve, it at least will reduce the amount of pulmonary regurgitation. It's 9 o'clock. What's the mortality of correctional tetralogy? Textbook said 2 to 5%. It may vary because anyway we can't not enough time to discuss the technique of transit here. Sometimes transpulmonary also may be required because if it's an Asian type of pathology with an extent to the subpulmonary, you may not be able to close the VSD fully, so you can have a transpulmonary approach also. Okay, any doubt? 9 o'clock, the time is limited. Any doubt on it? Because you should know everything about pathology when you go for an exam.
Sir, next class, can we discuss more on surgical management?
Yeah, sure. We can describe that because that's very important. They ask you how to avoid the bundle, what is the direction of the bundle, where how to take sutures, whether it should be continuous sutures, projected sutures, continuous in the area of the risk of producing heart block, and the rest are continuous. All those things, of course, can discuss that.
Yes.
To leave the PFO or to close the PFO. The general accepted theory is a newborn usually leave the PFO. If it's older kids, you close the PFO. And of course, how to deal with the LSVC. In this case, I think you mentioned double SVC, left and right, is it?
Yes, sir, bilateral.
Yeah. What's the incidence of the left SVC in tetralogy of Fowler? 7 to 10%, maximum 10%. So some of the percentages, that abnormal coronary artery is 5%. The canal type of VSD is in tetralogy about 2 to 7%. The pulmonary branch stenosis most common in the origin of the left pulmonary artery. Also, what happens to the absent pulmonary valve syndrome? How do they die? How do babies with absent pulmonary valve syndrome die? They don't die of heart failure. Of course, it produces right heart failure, as I said. There's a free pulmonary regurgitation. But the reason for they got massively enlarged aneurysmal pulmonary artery.
On the bronchus.
They may compress the bronchus also. That's why very often they die of respiratory problems. Okay, all right. Thank you very much. Any question you can?
Next class will